Okay. I think I'm going to start today. My name is Andrei Vavinsky, dear listeners. Welcome to the second webinar with the educational platform MedVoice. My name is Andrei Vavinsky. I'm a consultant anaesthetist at Bay Hospital in Torquay in the United Kingdom, and I'm acting as a host today. I'm very happy to introduce my very good friend and a colleague, Professor Javier Belda, who's an honorary professor of anesthesia at the Department of Surgery of University of Valencia in Spain, and a former head of the Department of Anesthesia and Critical Care and Hospital Clínico Universitario. He graduated in 1975 and made his doctorate dissertation initially in Bologna, in Italy. We have met in his capacity as a subcommittee part 2 member of the examination committee of the European Society of Anaesthetists, and his main interest lies in artificial ventilation. He's an author of more than 220 research papers and editor of 15 books. He was a research fellow at Radcliffe University in Oxford and in Boston, in Harvard University, Boston in 2006. He's a reviewer of many very famous journals, including JAMA and Lancet, Anesthesiology, GA, Critical Care Medicine, and many others. He has participated in enormous amount of congresses and gave numerous presentations, and was invited speaker in many congresses around the world. And today, his topic of presentation is advances in lung protection during mechanical ventilation. Also present with us is Professor Oleg Tarabrin from Odessa Medical School. So three of us will be happy to answer any of your questions when the presentation, which will be about 35 to 45 minutes, depending how it goes, will finish. Okay. Javier, all yours.
Thank you very much, Andrei, and thank you very much, Oleg, for presenting me. This is, for me, is the new platform, and I'm very happy to cooperate with you in this task. If you don't mind, I'm going to shut down my video camera because I don't like to see myself so during the presentation. Okay, so we are going to see today the advances on in lung protection during mechanical ventilation. Okay, so this let me check how this is working. Moving. Okay, so let me. So this is the.
Let's get to the board. Yeah, sure.
This is the summary. So the first we will talk about pathophysiology of ventilator-induced lung injury and the implication for lung protective ventilation. In the second place, results of lung protective ventilation in healthy and damaged lungs, 3 new concepts of lung damage related to mechanical ventilation, and finally, the protective ventilation rules at the bedside and the influence of ventilators that I love to show you even my own research. So you have to know that the mechanical lung injury is a mechanical ventilation induced lung injury, and this is really true. So you have a lot of papers, and look at this joke here. To prevent injury from the ventilator, Bob, which is here, will be giving you mouth to mouth for the next several days. So if you have to be ventilator, I'm not sure if you prefer a ventilator or you prefer Bob to give you mouth to mouth. Okay, so only to remind you, this very nice paper from ventilator-induced lung injury related to the mechanical ventilation. So the pathophysiology of this entity is related. If you look here, let me show you this. I'm not sure if you see the mouse. Yes, okay, I'm not sure. So this is pathology related to high tidal volume. High tidal volume, look here to in the upper part to the right of the figure, you see that high tidal volume produce overdistension, and this overdistension promotes barotrauma and what we call volutrauma. This is very well known from all of you. And in the left part of the screen, you see what is when the lung is inhomogeneous, there is a opening and closing of the alveoli. You can see the CT scan and inspiration and expiration, how the part of the lung opens and closes. That's this repetitive opening and closing is what we call atelectasis trauma. And these two things, barotrauma because of high tidal volume and opening and closing, that we call atelectasis trauma, I mean, apart from the biotrauma that you are well aware. So this is the three components of the ventilator associated lung injury. So if you can imagine very easy how to how is the basic mechanism for lung protection. So for prevent high tidal volume, use low tidal volume to prevent barotrauma and volutrauma. And to prevent repetitive opening and closing of the alveoli, you have to use PEEP to prevent opening and closing and to prevent atelectasis trauma. Preventing these two things, you avoid this mechanical injury and thus the biotrauma as well. So this protective ventilation with low tidal volume have been reviewed a lot of times in the literature, and this is the last review from the Cochrane, summarizing 5 randomized trials with a lot of patients. And you can see here in the forest plot that high tidal volume produce, when compared to low tidal volume, you know, the total odds ratio is from a risk reduction in 0.83, meaning that the low tidal volume is associated with around 70% of lower risk of mortality at 28 days when compare a high tidal volume about 5 milliliters per kilogram or low tidal volume about 7 milliliters per 6 milliliters per kilogram of ideal body weight. However, this is clear for you but look at this, the British Medical Journal Open Respiratory Research in a quite recent publication in 2019 in the guidelines on the management of ARDS, telling that it's not really tidal volume. If you look very close to the papers, there is no so clear results, and tidal volume may no influence anyway. So rationale is very high, and we consider today high or low tidal volume the gold standard for ventilate the patients during any stay in anesthesia or in critical care. So this is a nice paper related to patients without acute respiratory distress syndrome. This is a very nice review from Mari Sherpanetto, looking at more than 2,000 patients under mechanical ventilation, more than 2 days. They gather patients from 4 observational study and look at the survival curves in the right, looking at the higher survival is for those patients ventilated with lower tidal volumes below 7 milliliters per kilogram of ideal body weight, and is a higher mortality in those patients ventilated with more than 10 milligrams per milliliters per kilogram ideal body weight. So pulmonary complications are also increased. Look here, there are also pulmonary complications. The probability increases proportionally when you increase tidal volume in the x-axis, you see that above 6 milliliters, mortality, not mortality, sorry, but pulmonary complication increases progressively when you go from 6 up to 10, 12, and 15 milliliters per kilogram of predicted or ideal body weight. Okay, so conclusion is very clear that tidal volume above 7 milliliters per kilogram of predicted body weight is associated with increased mortality. You are well aware of this, so it's very clear today. But if you remember, it's not exactly tidal volume, because if the tidal volume is low, but the lung volume is low, a low tidal volume produces an increase in pressure, and this is for sure what makes the injury of the lung. Look at this very nice paper from 9 clinical trials, more than 3,500 patients, ARDS patients, looking at driving pressure as an independent variable associated with survival. Look at the left graph. In the upper part, you see that when you use a constant PEEP, a lot of patients, you see a different PEEP, and higher driving pressure. Look in the lower part of the graph that the mortality increased clearly. In the middle in the center of the image, you see that resampling patients, and they match driving pressure. When you use the same driving pressure, even with different PEEP, increasing PEEP, mortality is the same. But when driving pressure is decreased, even increasing PEEP, when you decrease driving pressure, mortality is decreasing. So it's clear that you see a multivariate relative risk of death. You see that above 15 centimeters of water of driving pressure, if you go with a tidal volume, but you produce a driving pressure above 50 centimeters of water, this is associated with increased mortality. So it's not really the tidal volume, but the driving pressure that you produce when you apply any tidal volume. So looking at the rules or the guidelines for treat ARDS patients with more or less severe ARDS. So these patients with acute hypoxemia, PO2 below 60, you have to set a low tidal volume, a driving pressure below 15, and use a PEEP FiO2 combination. This is what we call the ARDS net table. The table is here. You can combine a higher PEEP FiO2, and according to the FiO2, you adjust or you set the PEEP. However, so now the example is FiO2 of 0.5, PEEP should be around 16. Anyway, there are patients that hypoxemia is persistent, and you have to consider what we call the open lung approach, which is also including a recruiting maneuver to open the lung and then to titrate the PEEP to the best point to keep the lung open. And this is for most, let's say, more severe patients. So in summary, in this first part of the talk, the lung protective ventilation to prevent this ventilator-induced lung injury. In normal lungs, you have to use non-invasive or invasive mechanical ventilation with low tidal volume from 4 to 8 milliliters per kilogram of predicted body weight, because this reduces the mortality and pulmonary complications. Normal lungs or any stage of ARDS, but in patients with less aerated or more heterogeneous lungs, keep driving pressure always below 15 centimeters of water and plateau pressure below 30 centimeters of water. And you can set the PEEP according to the table, or in certain patients that you feel that are more severe, you have to recruit the lung and titrate the PEEP in what we call, and I recommend, the open lung approach. So let's move to the second part, the new concepts on lung protective strategies. So the new concept is what we call the patient self-inflicted lung injury, PSILI. So it's a nice study here, very nice draws. You can see here two normal lungs that we are going to calculate transpulmonary pressure. The first, the A graph is related to normal spontaneous breathing patient, and the B is mechanically ventilated patients, both cases of normal lungs. If you look at the alveolar pressure in spontaneous breathing, obviously at end inspiration, alveolar pressure is 0 because you are in close contact to the atmosphere. But the pleural pressure is -8 because it's your effort for inspiration. So transpulmonary pressure is 0 because it's the alveolar pressure, -8, transpulmonary pressure is 8. Okay, what happens in mechanical ventilation? In mechanical ventilation, you apply positive pressure, and this positive pressure produces, for example, 9 centimeters of water of alveolar pressure. But pleural pressure, now there is not active contraction of the muscles, and the pleural pressure is 1 centimeters of water. So transpulmonary pressure here is 9 of alveolar minus 1 of pleural pressure plus 8. The same transpulmonary pressure, and with the same transpulmonary pressure, you have the same tidal volume. So this is a spontaneous breathing. In normal tidal volume, you see normal transpulmonary pressure. So let's see what happens in a patient with a sick lung. You see that this lung is full with or filled with liquid, and because it's the edema, which is in the lower part, so the efficient volume of the lung is, let's say, half. And you are mechanically ventilated this patient. You ventilate this patient with normal tidal volume, but because the volume of the lung is reduced, with this normal tidal volume, you produce about 30 centimeters of water of alveolar pressure at end inspiration. Pleural pressure is about 5. So in this case, transpulmonary pressure is 30 minus 5, 25. This is clear over distension of the open lung and producing injury and edema because tidal volume is disproportional to lung volume. But let's imagine a normal lung that and in this situation, there is just ventilator with, let's imagine, non-invasive ventilation, just at 10 centimeters of water of pressure support, but the patient is doing a high effort. So having at end inspiration, our alveolar pressure of 10, which is the pressure support. Pleural pressure is doing an effort, a big effort of the patient of minus 15 centimeters of water, which is quite normal with high effort. So now transpulmonary pressure is 10 minus 15, again 25. So this situation in a normal lung with a high inspiratory effort, with a quite low respiratory pressure support, there is a high transpulmonary pressure similar that we get in a, let's imagine, relaxed or with a neuromuscular blockade, a mechanically ventilated patient with a sick lung. This is a normal lung and a sick lung, but both situations produce a high transpulmonary pressure, and this high transpulmonary pressure is what is the cause of the lung injury. So in this patient, self-inflicted lung injuries because is the patient with his effort who is doing the injury to the lung because of the high effort and high transpulmonary pressure. So look at this. So there are three circumstances that can happen. The first is in the left, controlled mechanical ventilation; in the middle, spontaneous breathing; and in the right, a partial assist ventilation. Look at we have in the lower part the same tidal volume, lung, transpulmonary pressure is, you can see here, flow in the upper part, alveolar pressure in the middle, esophageal pressure, and this is transpulmonary pressure or lung pressure in the lower part below or above the lung volume. So you see how the transpulmonary pressure is the same, but in the first situation in controlled mechanical ventilation, you see that the esophageal pressure is positive, with a spontaneous breathing is negative, and with partial assist or assisted breathing is negative, because it's the effort that you can see here. No problem in no one of the three situations. But let's imagine in this pressure assist control ventilation with, let's say, non-invasive or invasive, in a patient, relaxed patient, in the first situation, normal plateau, let's say plateau pressure with positive esophageal pressure, the transpulmonary pressure is, let's say normal. But when the patient is making an active inspiration, this transpulmonary pressure may increase. So this is what we call patient self-inflicted lung injury. So this is the first concept, the first new concept. Another new concept, or not that new, is what we call ventilator-induced diaphragm dysfunction. So it's the weakness of the patients that are critically ill and are mechanically ventilated for, let's say, a couple of days. So there is you can have a look of this very nice paper from Petrov in Chest 2018. There is an impairment of muscle quality and decreased muscle quantity, and both things reduce strength in one side and size reduction in the other, producing diaphragm weakness. This is not new. We know that the diaphragm reduces the strength when you are mechanically ventilated for even for a short time. But the new is that this atrophy or this reduction in strength that is seen during mechanical ventilation impacts clinical outcomes. For example, impacts weaning. This is a very, very nice and quite new paper looking at in close to 200 patients on mechanical ventilation, looking at the inspiratory effort, which was here quantified looking at the thickening fraction of the diaphragm using ultrasound. You can see in the graph that this is the 0% changes in the thickening fraction, telling that this in the center, this is the winning, let's say, winning liberation of mechanical ventilation, success of the winning. So patients which do not increase the effort, or the thickening fraction of the effort, the probability of success is very high, or higher at least, than those patients where the effort is reduced, or those patients with the effort is increased. So if you increase the effort or you reduce the effort when the mechanical ventilation is on for several days, the probability of winning is reduced. So this liberation from the mechanical ventilation is related to the magnitude on the thickness of the diaphragm in comparison to the baseline. Look here to the survival curves again, looking at the liberation of mechanical ventilation was much higher in the patients who did not change from baseline effort or thickness, and was reduced in those who increased or decreased the effort during mechanical ventilation. Okay, the message is clear. A normal effort is needed to promote winning. If you reduce your effort during the mechanical ventilation or increase, is because your strength is reduced and the possibility for winning is reduced. So 2021, which the principles of lung and diaphragm protective ventilation. Now we have two sides. In the left side is the standard baby lung stress and strain. So the over distension and opening and closing. So it's excessive inspiratory assist with high tidal volume, high driving pressure, or excessive PEEP producing over distension, insufficient PEEP producing opening and closing, the recruitment. But this is what we knew many years. But today, there is not only the VILI, but the PCILI. So, and the protection is to optimize the diaphragm effort and synchrony. So PCILI is produced because there is an insufficient assist that produce a high effort or high drive, producing injurious efforts, okay? So, and also, if you look at the diaphragm, if you look at the expiratory desynchrony, or you see the longitudinal atrophy because excessive P, for example, or diffuse atrophy because of excessive assist, this diaphragm injury also produce the injury. So we have the two sides, one related to volume and pressure, even the PEEP opening and closing, and in the right side, the PCILI because of injurious effort, because of high effort, and second, because of diaphragm injury related to atrophy. Okay, so on this very, very nice paper, Intensive Care Medicine 2020, they said we propose target for diaphragm protection based on respiratory effort, that you have to be moderate the respiratory effort, and patient ventilator synchrony, which be more, let's say, protective for the transpulmonary pressure and for the diaphragm. Okay, so the rules, there are basic rules at the bedside. Tidal volume, okay, we know that, 6 milliliters, okay. Second, airway pressure, looking at the compliance, plateau pressure below 30, driving pressure below 15, and adjust an optimal PEEP. You decide the way, opening the open lung approach or the PEEP file to table, whatever you want, okay? You decide the way, but you have to adjust some PEEP. But today, we have to say that we need to preserve spontaneous breathing with normal inspiratory effort. So detect excessive effort and try to reduce the effort if it's high, or try to increase the effort if it's low. So you have to detect the effort. You can measure the effort, of course, using esophageal pressure, the PO1, occlusion, or using the diaphragm thickness that we have seen. And also, and I'll show you the two new index, that is the flow index of the nasal pressure. But not only preserve the normal inspiratory effort, but promote synchronization. Okay, so let's look at this. To detect the excessive effort, there is a very nice paper, and it's very easy to detect the effort, because if you are ventilating in volume control ventilation, you see the typical shape of the peak pressure, plateau pressure, and expiration, right? So look at this, how this standard shape of the airway pressure is depressed And this depression and this modification in the right part of the figure, you can see this depression of the airway pressure telling you that there is someone, you know, sucking the flow, someone is breathing on the mechanical breath and produce this alteration of the airway pressure. And it's very easily recognized this effort which is produced in the same cycle that the mechanical ventilation. Please have a look and detect this alteration of the morphology of the airway pressure, because it's indicating that someone is breathing at the same time and sucking and producing a high effort. You can see in the lower part of the graph, no muscular pressure of 5 or 10 or 20. Look, when you have a patient with doing an effort of 20, so look at how the typical shape of the airway pressure is modified. So this is a new study with a very nice paper from 2021. It's what we call flow index. I remember that we had a stress index.
Just count to 5 and then crack on. Okay, go for it. Thank you.
Okay, so the point is how to detect the effort. This is a very simple way. If you are ventilating a patient in volume control, you can see here in the upper part of the graph the typical shape of a peak pressure, plateau pressure, and expiration. So there is no muscular pressure, no effort of the patient, because it's a mechanic control ventilation. But in case that the patient is doing any effort, look at 3 different levels of the effort. The first one, the patient is doing some effort here, about 5 centimeters of water, and you can see here how the shape, the normal shape of the airway pressure is changed. So when the effort is 10 or even 20, you see how progressively the normal shape of peak and plateau pressure is totally changed. And when you see a airway pressure like this, is because the patient is sucking, is taking the air with a big effort, and the patient is changing the airway pressure curve, the normal airway pressure curve. So please pay attention to the airway pressure curve when you ventilate a patient. And if you detect this change in the airway pressure shape, is because the patient is doing effort. Okay, this is a new thing. This is for quantification today of the effort of the patient. Here in the graph to the upper part of the upper right part, there are two situations. You see in the left, there is a no effort or minimal effort, and the pressure is a square wave here, and in the other part is also a square wave. But in the first one, the patient is doing no or minimal effort only for triggering the ventilator. You see the airway and the alveolar pressure below the shaded part of the graph. But in the second curve, this shaded part is higher because the effort is higher. Look what happens in the flow. The flow in the first part, because the inspiratory activity is almost passive, you see that there is a concavity, the upwards concavity of the flow curve. But when the patient is taking gas, this passive inspiration, this concavity, change the shape to a convexity, upwards convexity, indicating that the patient is taking the air and producing a more positive flow. Flow to him, and the both shapes are really different. So it's clear to see that when there is this upward convexity, and this upward convexity is reduced, you can measure this shape, and is this shape and the measurement of this shape is what we call the flow index. When the flow index is high, it's because the effort is high. When the flow index is reduced or even below 1, is because the ventilation is more passive. Look here, the flow index, how the flow index predicted the effort in the y-axis and the flow index in the x-axis. Look at very good correlation. So look also not only to if you are ventilated with pressure, if there is any effort, you cannot see the pressure. The pressure is not telling you nothing, but is the flow. Then if the patient is ventilating, you will see how the flow is moving upwards and producing this typical shape, convexity, upward convexity, indicated the effort of the patient. And finally, this is a very recent paper looking at this patient. Look at what is located in the nose. In the nose is located just a vein catheter. Well, in the nose is placed two catheters for this study. One went from the line, was inserted through the nose and going through the esophagus. But the other is just a small vein catheter through a nasal prong, like ear prongs that you use for prevent the sound. And this, the pressure is measured inside the nose when the nose is occluded. You see here how in the upper part and in the lower part, there is the esophageal pressure, and in the nose pressure, and you see that these changes in pressure are totally coordinated with the esophageal pressure. And when they observed the correlation, they saw a very, very good correlation between the esophageal pressure and the nose pressure, not only in patients, because this was done in small patients, you know, I can't remember, but about 30 patients during the baseline measurements, but after 24 hours with the patient with high flow or even non-invasive ventilation, the correlation between the esophageal pressure and nose pressure was very, very good. So if you want to make a quantification of the effort, you can also measure the nasal pressure using this very recent method. Okay, so basic rules. So, and in this one, okay, I was not, sorry. So it's basic rules at the bedside, but in this case, it's for the ventilator and not for the patient. We know what to do for the patient, but what do we need from the ventilation? So we need an accurate ventilator delivering a good and well-monitored tidal volume, an accurate monitoring of driving pressure, plateau pressure, a PEEP, and we need optimal pressure and flow delivery. So basically, when we face a patient and we see that the patient is performing at a high effort, why this patient is performing a high effort? So it's because the patient is low compliance or high resistance, or because we have wrongly set the ventilator, or because there is asynchrony, or because the patient is with pain, anxiety, sedation is wrong. So that happens many, many times, many instances at the bedside. So, and sometimes we say, I'm not able to set this ventilator, so I give up. So I go to bed in this horrible duty. They have a lot of patients, a lot of problems. I'm fed up, I give up. Okay, that's correct. But so the patient is doing a high effort because of the tidal volume, because of what, but what is the responsibility of the ventilator? So sometimes it's you, but why not the ventilator? So we have a lot of ventilators, and not all ventilators perform the same way. So patients in ICU, we have a different ventilators, and the performance of ventilators is quite independent of the size, of the weight, of the height, of the price. So you may have a small ventilator, but very accurate and very good, and a big ventilator, very expensive, not performing very well. So I would like to show you our bench laboratory for analysis of ventilators. We use a model of lung of, you know, is here in the left part of the slide. The AESL 5000 is a prototype of lung model that we ventilate with many ventilators, and we have obtained a lot of results using all these ventilators, even other ventilators for home use or ward use, and we have the analysis of all this. Look at this, for example. This is a typical sample of what we get. So in yellow, there is the yellow line is the airway pressure, and green line is the effort of the patient. Look at here. So initially there is a drop in airway pressure, and then a rise in airway pressure. The same in this ventilator and the ventilator, the Philips V300, that with the Hamilton 3. But look at this. The airway pressure drops in the first case far below the PEEP. So all this pressure that drops below the PEEP is the effort, because the flow, the gas flow is not enough to compensate the effort of the patient. Look at this small Philips Evo or EV300. Look at how this area is much lower. So here, the same effort of the patient is best matched with the flow, the gas flow, and this do not produce a decrease in airway pressure, indicating a better matching of the flow and the effort of the patient. Another example, so the patient is the snake. Because of, look at this, the effort produced a reduction in the airway pressure in Hamilton C3, but with the Philips, the EV300, look at how the pressure increases rapidly and do not produce this, let's say, like this shape indicating the effort is not compensated with the flow. Look at the differences in the flow is the red line at the left side. There is a flow not reaching a high peak flow, and in the second to the right, the red produces a high flow and do not produce a drop in airway pressure. So this is examples of pressurization. So is the pressurization what we call the percentage of pressure delivered at 300 milliseconds. There is different conditions. You see in the lower part of the three graphs, normal patients, obstructive, restrictive, low leaks, low effort, low, high effort. Look at the pressurization is the ideal is, let's imagine, as 100%. So you see here how in the Dreger-Savina is close to the higher values are about 30. The Hamilton C3 is from 30 to 40, and the Philips EV300 is higher. So look at how the pressurization increases according to the ventilator. So if the patient is doing a big effort and you are using a Savina V300, you have to change the ventilator. There is no way that Savina may offer or could offer you a higher pressurization rate because the flow is not enough to compensate the effort of the patient. Finally, to show you asynchronies related to the ventilator. Look at this case, the Dreger-Savina 300. Look at how there are a triplet of reverse triggering here. But here, for example, I show the Philips because it's a very small one and very cheap one. Look at the perfect synchrony with the Evo 300. So in this case, is the Hamilton C3 compared to the Evo, how there are the asynchronous episodes of double reverse triggering in the left part of the slide, and in the right part, the perfect synchrony with the Evo 300. So this is my last slide, giving you a take-home messages. So this is a stairway to heaven. So the bottom line is for any patient in any circumstance, you have to apply lung protective ventilation, always with the optimal ventilator to any patient, correct? So choose a good ventilator first, okay? This is you remember the song of Led Zeppelin, The Stairway to Heaven? There is a solo guitar in the middle of the song, which is perfect. And this really a stairway to heaven. So in the first part of the step one of this stair is the basic rule. So tidal volume and then apply a table with a 502 PIP. This is to prevent VILI. The step two is make let's say, a personalized lung protective ventilation, monitoring plateau pressure, trying to have a driving pressure below 15 centimeters of water, and then secondly, set tidal volume and PEEP to have the driving pressure around 15 centimeters of water or below. So step 3, so please promote spontaneous breathing, not only with non-invasive ventilation, but with invasive ventilation, but with spontaneous breathing, prevent high or low effort to promote winning. In this case, preventing high or low effort, you are preventing the PSILI, patient self-inflicted lung injury, and protecting the diaphragm. And finally, the step 4 is to detect and prevent asynchronous, select an adequate ventilator for preventing asynchronous, preventing at the same time or protecting at the same way the diaphragm from all this in this setting at the bedside. So these are 4 steps that will drive you to the real lung protective ventilation today in 2022. Thank you very much for your attention.
Fantastic. Hello. Thank you very much, Javier, for the very nice presentation.
Thank you.
I have enjoyed listening to it, and there are no questions yet, but I just wanted to ask you, it's a very nice strategy that you put back in to win the patients from the ventilator, and very simple rules to follow. And certainly we in our department changed our settings on the ventilator machines for the anesthetic part of it on default from what it used to be 10 mils per kilogram to now 6 mils per kilogram. And for everybody we start is about 300 mils of a tidal volume. Would you have any recommendations for the listeners who majority, well, I'm not sure, but lots of them work in not just in intensive care, but in theaters as well, of what would be the strategy for somebody who is having a say, long case, 3 to 4 hours? What will be their simplified strategy of lung protection, please?
Yeah, I mean, for sure, there are some of the 2 or 3 basic rules that you can follow and I recommend to everyone. First is to use always low tidal volume. And then that you know that when you anesthetize a patient, there is always some collapse of the lung. So, but you don't know exactly the collapse is higher or lower. So maybe it's not to apply recruitment maneuvers to everyone. Maybe is not worth, because nobody needs for a rule for applying recruitment maneuvers, but you have to detect this collapse of the lung, and it's very easy, because if you go from let's imagine that you are working with a 40% FiO2, just drop FiO2 to 21% for 3 minutes. If the patient had a normal oxygen saturation when you started the anesthesia was, let's imagine, 99, and now drops to, let's imagine, 98, so there is no problem. You know, there is no much collapse. But if the oxygen saturation drops to 85 or 86, there is a big collapse of the lung. So I would increase the pressure. I mean, suddenly increase, let's imagine, PEEP of 15 for, let's say, 5-6 cycles, and then move back to the PEEP that you set in the beginning, but with higher PEEP. Let's imagine 2 centimeters higher. So, and then again, maintain the anesthesia, and after 1 hour, move back FiO2 to 21%. And so you do the same. And if the patient is still open, I mean, the lung is still open, oxygen saturation will be kept, will be at the same, let's say 94, 95. But if the patient is collapsed again, you have to retreat again the lung and apply a higher PEEP. And this is a rule for obese patients, small patients, whoever. So apply first low tidal volume and some PEEP, 3, 4, 5. That's correct. After 30 minutes or 1 hour, drop FiO2. And if the FiO2 and if the oxygen saturation drops below 90%, you have a collapse. You have to make some recruiting maneuvers, applying some high PEEP for several cycles, and then apply a higher PEEP that you had before. And that's it.
Okay, thank you very much. Which sort of recruitment maneuvers you would recommend as best, apart from just applying PEEP?
I think that as a rule in anesthesia is, imagine that you are ventilated with a PEEP of, let's say 5 or 3 or 5. Just apply 2-3 cycles with 10 of PEEP and 2-3 cycles of 15 of PEEP. And then when you are applying the 15 of PEEP, leave this for 5, 6, 7 cycles. After 7, let's say 10 cycles of 15 of PEEP, lung is recruited. So move back to the previous PEEP, the value that you understand that is correct. If you had 3, put now 5. If you had 5, put now 7, and just maintain the ventilation. For this recruiting maneuver, you can apply the PEEP the FiO2 that you want. You don't need to stay at 21%. No. For sure, you can increase the FiO2 to 50%, do the recruiting maneuver, and then when you have reset the PEEP, 2 centimeters of water above the PEEP that you had before, now you have to reduce the FiO2 and see what is the result. So if it was 90 and now it's 95, lung is recruited.
Okay, very good. Do you remember in the past there was this function on some ventilator called PSI, where you press on that function and the ventilator will double the tidal volume that was set, tidal volume. It was called PSI function. It will double the tidal volume and give 2 double tidal volumes. And then for some reason, this function disappears. And to me, it is a type of recruitment maneuver.
Absolutely.
What do you think of that?
Yeah, absolutely. It's a recruiting maneuver. So, but now we have removed the site because maybe not in the operating room, but in critical care, if you apply site and you imagine that you make 2 sites per minute, after 2 days, you have applied thousands of sites, and this produce injury and increase the possibility of injury in 2 days or even in 1 day, or because the number of sites is very high. And if you want just to open the lung, why don't you open the lung just 1 time with a site or increasing PEEP, as I said, and then apply PEEP. If you apply enough amount of PEEP, you don't need another site, because the lung will be open for the rest of the surgery if you don't change nothing. If nothing changes, nothing else.
Yeah, this is the answer I was hoping that you gave, because I think applying manual site every now and then is actually good for the patient, but it's the whole mode of ventilation that was applying site too often that actually was damaging in terms of volume trauma and barotrauma, wasn't it? So that's why
I think that we are the anesthesiologists. We are used to recruit the lung after during a thoracic surgery, when we have to open the lung after the collapse. We see how the lung is open and open progressively, and we see how the lung is recruited. So you can imagine that the lung is collapsed and doing a site manually, or that's correct, that's perfect. But then you have to apply some PEEP to prevent recollapse. So, and that's it. So very easy.
Absolutely, that's fine. Do you believe in the harmful, in the harm that is caused by a high FiO2? I mean, what is the cutoff that we should really kind of, what is our goal to keep? I mean, 21% for lots of people is a bit drastic, but what would you recommend for during anesthesia in normal healthy lungs?
So I accept anything, because if you say that the high concentration kills the patients, okay, I'm not going to tell nothing against. But if I'm in the operating, on the table, please give me high FiO2. I'm safer with high FiO2. And what I can tell is that after 2 hours, 3 hours, 6 hours of high FiO2, let's imagine 60, there is nothing, no complications related to a high FiO2. So, FiO2 kill or damage the lungs. Yes. But if given, let's imagine 100% during days, or a high 80% during days, but not during anesthesia, we haven't demonstrated any damage, no damage at all, no collapse, no problems, and less hypoxemia and better survival with higher FiO2 during anesthesia. Don't blame yourself because you are using 80% or 100% during induction, and then you move to 50 or 60% during anesthesia. You don't need to go there. So if the lung is open, 40% of oxygen is enough. But nothing happens if you are using because of, I don't know, because of your mother-in-law. I don't know. You can use it 80%. Okay, that's correct. No problem. You are not going to kill your mother-in-law because of the high oxygen concentration.
Well, the reason I've asked that question is because we have one or two colleagues who are really high on not ever going anywhere below 30% with saying that oxygen, too high concentration of oxygen is damaging to the lung. You will produce the atelectasis, lungs will collapse. You will never re-recruit them if you're using too high oxygen. I mean, that obviously comes after a lot of hours of ventilation, isn't it? And that is correct. But during the 2, 3, even 4 hour case, it doesn't matter that much, as far as I understand.
And always, if you want to check the collapse, please go to FiO2 21%. And with that, if oxygen saturation drops, it's because you have some collapse. And with the lower oxygen saturation, the collapse is higher. So this is indicating what to do. If you're following your pulse oximeter during anesthesia without touching, doing any change in your FiO2, and you see that the SpO2 is going down from 98 to 96 or to 95, so something's happening there. So be careful. So try to see what is the saturation at 21%, and please do something. So try inflating manually and increase a little the PEEP, etc. Sorry, Andrei, I think that your microphone is mute.
Okay. Yes, I'm muted. Sorry. Okay, so I have a question from a listener here who is asking, in first 24 hours in ARDS, they recommend to use muscle relaxants to exclude the spontaneous effort. Sometimes they say this process is prolonged and it's very difficult to come back to spontaneous breathing. What are your recommendations?
Okay, patients are really different. So there are patients that you are fighting, trying to synchronize with the ventilator, and it's impossible because of the effort, because complex, many things. You cannot recruit the lung, you cannot open the lung. So they are very difficult. This patient needs some muscle relaxant during, the least time possible. So just I can't ventilate this patient. Okay, you can use it, muscle relaxant, but try to remove muscle relaxant as soon as possible and start, let's say, starting not only spontaneous breathing, but at least try to synchronize mechanical. If the ventilation is correct, if a patient is breathing, not assist, but controlled ventilation, and controlled ventilation is well set, so the patient let the ventilator ventilate him because he's more comfortable that some machine is helping you. And then this promotes spontaneous breathing. So I do not recommend use muscular blockade during mechanical ventilation for every patient, but just difficult patients.
Thank you very much, Javier. The same listener is asking about how do you measure the nasal pressure?
Okay, no, it's very new. I haven't measured it yet. So, but I read this paper and I knew that in pneumology, we measure what we call sniff pressure. A sniff pressure is doing a sniff, something like trying to, So, and the pressure
breathe in.
Trying
to breathe in,
exactly. And the pressure that you generate in the nose or in the mouth during this sniff pressure is totally related to the muscle pressure, for a spontaneous breathing patient. And this paper that was in critical care, a few days ago, is just using a hair plug. So you put the hair plug in the nasal, in the nostril, right? So, and you make you perforate the hair plug with a venous catheter. So you have one part of the venous catheter outside, and then let's see, it's a plastic, of course. You leave just the plastic, and the end of the catheter is inside the nose, and you connect this to a pressure monitor, and you see the changes during a spontaneous or high flow or non-invasive ventilation. The changes in the nasal pressure are very well correlated to the changes in pressure in the esophagus. It's just there is no more clinical data than this paper that with 30 patients, but it's the first time that has been described for the patients with spontaneous and non-invasive ventilation.
Okay, interesting. It's seems like a very simple idea. First, ear plug, perforate with tube, measure the sneeze pressure. And I suppose at the same time, one can measure the inspiratory flow rate, isn't it? Because that will also tell you what if somebody is generating 15 liters per minute rather than 30 liters per minute, you know that their inspiratory flow rate that they generate is low, and it's too early to extubate them. There's one more question there. Can we use described recruitment maneuver for ARDS patients, or it fits only for patients with normal lungs?
No. The maneuver is quite similar for both. The only point is that because the idea is the opening pressure, the pressure that opens the lung is the peak pressure, is the upper pressure, right? So let's imagine you use pressure control of 20 centimeters of water. It's very high. Okay, 10 centimeters of water. You use pressure control of 10 centimeters and you apply a PEEP of 10. What is the opening pressure? It's 10 of PEEP and 10 of pressure control. So the opening pressure is 20. If you increase PEEP from 10 to 15, now the opening pressure is 25. Now you go from 15 to 20 PEEP, now the opening pressure is 30. You go to the PEEP 30, now the opening pressure is 50. So you have to increase the PEEP just to prevent to have a big movements of the lung. Oh, you know, if increasing the PEEP, you increase the resting volume, and you don't move a lot the lung because driving pressure is always the same, is 10. Okay, so the difference between a normal lung and an ARDS is that rising the PEEP from 10 or from 5 to 15 in a normal lung, you recruit the lung. With opening pressure of 25 or 30, that's enough to open the lungs in a standard anesthetized person, even an obese patient. So PEEP from 5 to 15 with pressure control of 10 or 15. So we're going a pressure up to 30 or 35. That's enough. Sometimes in ARDS, you need to increase this pressure up to 40 or 45, the peak pressure. So PEEP plus pressure control.
Okay, brilliant. Thank you very much, Javier. One last question, I think. One last question.
Okay.
Julia is asking, have you ever used recruitment for newborn?
Not really. I haven't treated newborns. Just consulting to the pediatricians, but many years ago. But so I think that the physiology is quite close. So if the lung is collapsed, you have to apply pressure to open the lung, even it's a baby or an adult. You need volume in the lung. A certain volume, which is small in a neonate and bigger in an adult, but the pressure is the same. The pressure for opening a lung in a neonate or in a rat, which is a very small lung of a rat. What pressure would you apply to a rat to ventilate a rat? The same pressure that to an adult. If you apply to my lung a 10 centimeters of pressure, I will breathe or I will receive 500 centimeters, 500 milliliters, because my compliance is 50. 50 times 10, 50, 10, 500 milliliters. So imagine the same, you apply the same pressure to a neonate and you apply 10 centimeters of water, but his compliance is not 50, but 5. So the volume that you administer is 5 times 10, 50 milliliters. And for a horse, the 10 centimeters of water for a compliance of 500, you deliver 5,000 milliliters. So that's the reason, because the pediatricians apply always applying pressure. You apply the same pressure to every neonate, and with a small lung they will deliver 5 milliliters. To a bigger lung they will apply 10 or 20 or 50 according to the size of the lung. So the question is very good, because would you recruit the lung? Yes, of course, because it's the only way to ventilate a neonate. I don't know how the maneuver can apply the same way that in an adult, but to recruit a lung is the best way to recover the lung volume, and applying the same pressure, you will deliver a correct volume.
Yep, so principle is the same, basically.
Exactly.
Okay. Thank you very much. Javier, thank you immensely for your presentation today. It's been a blast. You are a very good speaker, and it seems like you spent your life studying this subject, and it's great to hear from you and great to see you even through the screen again. And I look forward to visit Valencia once again at some point. Thank you for participating in this webinar. We had about 100 listeners at High Point following us today. There were a few questions. And thank you again. Oleg asked me to apologize for not staying till the end, because he had to go and attend some urgent operation in a hospital, apparently. So he couldn't be with us.
Okay, a final word just to say, if I've been, Ukrainian people listening to this talk, please, I would like to send you all my support and just to wish all the best. I mean, all the best for finish this stupid and aggressive war and this invasion, stupid invasion from Russia. So I'm really sorry about this war, and please, you know, all my, from the bottom of my heart, you know, have all my support. Thank you for being there.
Thank you very much. I think I will translate because this is very important what you said, Javier. Для тех из вас, кто не очень хорошо понимает по-английски, я хотел сказать, что Хавьер для всех слушателей из Украины особенно передает сожаление с тем, что вот эта ужасная война разразилась между двумя нашими странами, и он надеется, что она закончится как можно скорее, и он, в общем, вашим мужеством восхищается. Thank you very much, Javier, for this message. This is the reason that we are all involved in trying to help Ukraine, trying to raise a little bit of money through these presentations. If you consider donating for this, please do watch the website of MedVoice. We will be arranging more. I've already spoken to 3 new speakers who will be presenting for you on different topics, not necessarily related to war injuries or anything, because despite what's going on in Ukraine, life Boyka from Serbia, Boyka Netkovic, decided to give us the presentation, and I'm speaking to Nicola Brogli as well, who works in your country in Madrid, but originally from France, and speaks all 3 languages for us plus English, who will also probably speak about his beloved obstetric topics, no doubt. Thank you very much to all the listeners. Tatiana, you're absolutely right. The knowledge is the strength. I'm following the live chat as well, and there are some lovely messages there thanking us for the support, and it's great to be with you guys. But I will better send my patients, and thank you very much, Javier, again, and have a good evening, everyone. Bye. Slava Ukraini.
Slava Ukraini.